Good evening. We come to the second session. I think the first we have a talk by Professor Andrew Coates. I think he's on the line.
Sir, I have it pre-recorded, sir.
Okay. Dr. Chopra, any comments from you to introduce Dr. Coates?
Session, and then we'll have the comments at the end.
Yeah.
Hello, my name is Andrew Coates. I'm President of the Heart Failure Association. It's my great pleasure to present at this Heart Failure Association of India meeting. I'll be talking about the evaluation of kidney function throughout the heart failure trajectory. It's my great pleasure to present at this very important meeting. Here are my declarations. As a background, we know that heart failure and renal disease share common risk factors and promote the development and worsening of each other when they coexist. The prognostic significance of renal function, however it's measured, depends on the clinical context, and there are important features about how best to assess renal function and the adequacy of diuretic treatment and congestion, as we will see later. Acute exacerbations of heart failure and congestion frequently occur in the background of impaired renal function, particularly in the presence of heart failure with reduced ejection fraction, and further acute worsening, and then the effect of decongestive therapy, either transient or sustained, needs to be evaluated. The pathophysiology of impaired renal function, acute heart failure, and a response to therapy is incompletely understood, and we have a self-inflicted lack of data about how best to manage patients when estimated GFR is less than 30, because that was a common exclusion factor for many of our heart failure trials. Here is the guidelines from the ESC in 2012, and if you're very sharp of eye, you will notice that the very first element, diuretics to relieve symptoms and signs of congestion, is in a slightly different blue color, and that's because it was a very late addition. What this showed is the people writing these guidelines were really concentrating on treatments that had major mortality morbidity trials, but had, at least until the very end, not thought to give any advice on how best to use diuretics, which are of course an essential part of the management of chronic heart failure. In 2016, we did update the algorithm, and you see here down the left, diuretics to relieve symptoms, signs of congestion is a standard part of treatment throughout the algorithm, but it's always put down there that we should use the smallest dose we can to achieve euvolemia. The problem is we don't give a lot of guidance about how to assess whether a patient is euvolemic, whether they do have adequate control of congestion. And as I'll come to later, it's important that we do control congestion. So we did two position papers recently through the Heart Failure Association. The first with Wilfred Bullens as first author, which was the use of diuretics in heart failure and congestion, a position paper of the Heart Failure Association. And the second was the evaluation of kidney function throughout the heart failure trajectory, also a position paper of the HFA. It's important when we're looking at control of congestion, we realize what a powerful group of drugs we have. We have multiple diuretic agents that work in different places in the nephron. We mainly use loop diuretics for control of congestion, and they act, as the name suggests, in the loop of Henle, where 25% of sodium resorption occurs. But we can also affect sodium resorption in the proximal convoluted tubule, and two drugs, acetazolamide, that's not so commonly used, but now the very new class of drugs, the SGLT2 inhibitors, affect sodium handling in the proximal convoluted tubule. We have the thiazide diuretics that affect sodium resorption in the early distal convoluted tubule, and we have mineralocorticoid receptor antagonists that affect sodium potassium handling in the late distal convoluted tubule. So we can combine multiple diuretic agents that affect different parts of the nephron and overcome diuretic resistance in the majority of patients. Here is a central algorithm of our recommendation paper that deals with how to manage congestion in the acute heart failure patients. And it's very complicated, and I direct you to the paper to have a look in more detail, but let's just say it gives practical advice for the early stage of treating the congested, acutely decompensated patients. And the fundamental principle is you should move fairly quickly. Standard practice is to have a patient in acute heart failure, give them a dose of IV diuretics that perhaps based on your clinical judgment, and then see how things go and perhaps review it after a day. What this recommendation is in a patient who's congested with volume overload, if they've never had loop diuretic before, you can start with a dose of 20 to 40 furosemide equivalent intravenously, start urine collection after empty bladder, and wait to look to see the impact as early as 2 hours. If they've already been on a diuretic dose, then give either 1 to 2 times their usual 24-hour oral dose intravenously straight away, and also start urine collection. The important thing in this algorithm is after 2 hours, you do a spot urinary sodium analysis that gives you an estimate of how things are going as early as 2 hours, and then you do a full 6-hour collection where you look at total urine output. If the urinary spot sodium is above 50 to 100 milliequivalents per litre, then you're getting an effective natriuresis and diuresis. If the 6-hour urine output is greater than 100 to 150 mils, then you're doing all right. If you are doing all right, you can persist with a similar dose until the patient has reached euvolemia. If you're not doing all right, because these two things having failed, then you need to double the dose of IV diuretics and reassess after another 6 hours. You can repeat this 3 to 4 times over the first 24 hours. So you can get a much higher dose of intravenous diuretics being tried within 24 hours of admission, so that you have a chance of getting early control of congestion, which relieves the patients and possibly has long-term beneficial effects. This is the acute treatment phase, the early evaluation phase, and the early response phase. And even after 24 hours, you've got a long way towards controlling the congestion in these patients. At the same time, in the printed diagram, you'll see parallel interventions and parallel evaluation you will undertake. Then after the first 24 hours, you then continue using the diuretics and possibly even continuing to increase the dose until you've reached a 400 milligram equivalent furosemide dose to get an adequate urine output of 3 to 4 litres per day. And if you're not achieving that, then use combinational diuretic therapy, adding thiazides or acetazolamide or SGLT2 inhibitor or miloride, according to a table given in this manuscript. The important part of this is that we should move fairly quickly. We should have accurate estimate of urine output, and we should not be scared about accelerating the use of high doses of diuretics and combination diuretic therapy to achieve euvolemia more quickly. Now I'll come to a more difficult controversy, and that is the trade-off of getting rapid decongestion versus apparent increases in creatinine or worsening of renal function. Many observational studies suggest that renal impairment or worsening renal function is related to poor outcome in patients with heart failure, particularly reduced ejection fraction, but all heart failure. You see here that the hazard ratios are consistently above 1. But at the same time, persistent congestion in a patient with acute heart failure, in other words, inadequate diuresis, is also associated with worse outcome. Whether you look at residual signs and symptoms of congestion, whether you look at pulmonary capillary wedge pressure elevation, or whether you look at natriuretic peptide elevation, patients who are less well decongested have a higher mortality and hospitalization outcome during follow-up. So we have a trade-off. Do we go for higher decongestion, higher diuretic dose to get better and more adequate decongestion and prevent this adverse effect, or do we worry about apparent worsening of renal function, elevated creatinine, when we give more aggressive diuretic therapy? And that's partly answered by a couple of observations, one done by Marco Metra and one done by Dr. Wattab, that looked at patients who had worsening renal function as assessed by an increasing serum creatinine during decongestion compared to whether they've got residual congestion or not. And in all cases, the worst outcome is when you have a combination of residual congestion with worsening renal function. However, if you then look at the next worst case, is patients that remain with some residual congestion, but they don't have worsening renal function. And it's better to have worsening renal function provided you have decongested the patient. Similarly, in this other study, worsening renal function with congestion is the worst. But if you have worsening renal function, but no congestion, you have a good outcome. So it's worthwhile getting adequate control of congestion. And you can, if you do that, you don't have to worry about the adverse effect of worsening renal function nearly as much as if you do not control the congestion. So there is the term coined of pseudo-worsening renal function. And pseudo-worsening renal function is when you get an increase in creatinine in response to diuretic therapy during an episode of acute heart failure, but it's associated with a simultaneous favorable ongoing diuresis and improvement in heart failure status. That shows that your decongestion is doing what it's designed to do. And the increase in creatinine is only a temporary feature that's not associated with long-term worse outcomes. You also see this syndrome of pseudo-worsening renal function during the initiation of neurohormonal antagonist therapy, particularly in the setting of HFrEF, and even more recently with the recent SGLT2 inhibitor trials, we've seen DAPA-HF and EMPA reduced. We also see this pseudo-worsening renal function in patients with the initiation of SGLT2 inhibitors in heart failure. This feature, when done in these settings, is not associated with a poor outcome because it reflects changes in intrarenal hemodynamics, which are a beneficial effect of our treatments, whether they be diuretics, neurohormonal antagonists, or SGLT2 inhibitors, hence the term pseudo-worsening renal function. The treatment benefits of neurohormonal blockers or congestion relief or SGLT2 inhibitors outweigh the adverse events of apparent worsening renal function. So therefore, in summary, changes in renal function during admission for acute heart failure, we should look for diuretic response, we should use higher doses diuretics, and we should use a more aggressive, rapid up titration of dose of diuretics to achieve adequate urine output and speedy decongestion. A good loop diuretic response is seen if urine sodium concentration is greater than 50 to 70 milliequivalents per litre 2 hours after IV administration, if urine output is greater than 100 to 150 mils per hour during the first 6 hours, and if total diuresis exceeds 3 litres per day for the first 24 hours of the day. So the approach to worsening renal function in acute heart failure is to look at use of decongestive therapy and assess whether there is an elevated creatinine. If it is seen, then make sure there's not another feature such as post-renal obstruction, such as prostatic obstruction. Assess the diuretic response to see if they're responding to your conventional or normal doses of diuretics. If the response is good, then you should persist. If the response is poor, you need to check that there's still ongoing congestion and assess whether there are hemodynamic reasons for the poor response, such as raised intra-abdominal pressure, and check that perfusion is adequate. Next, we need to then look for overall clinical features, whether there's hypoperfusion and hypotension. If it's present, you need to optimize hemodynamic status. If it's absent, you can increase diuretic intensity and consider the addition of IV vasodilators. So we can get worsening renal function due to congestion, where we have to push decongestion. We can get it with therapy-resistant worsening renal function, but patients require ICU admission and may require invasive hemodynamically guided therapy, and we may consider ultrafiltration. The approach to worsening renal function in chronic heart failure is more complicated, and I refer you to this algorithm within the paper, but it basically involves assessing the standard life-enhancing treatments we recommend for our patients and checking that the up-titration of RUS inhibition is tolerated in terms of renal function, and gives practical advice on what levels of temporary increase in creatinine are acceptable, as well as how to monitor potassium levels and creatinine clearance. It is worthwhile doing these, putting this effort in, because we know that these treatments, particularly ACE inhibitors, beta blockers, do benefit our patients, but only if adequate doses are given. Furthermore, if you have a patient commenced on an ACE inhibitor who gets a renal contraindication, a relative renal contraindication, such as an elevated serum creatinine, if you can persist with the ACE inhibitor, they do better. So here you have a renal apparent contraindication to ACE inhibitors. And if they have those, but despite that, they are persisting with the ACE inhibitor, they do extremely well, as shown by the SOP curves. If they contraindication to ACE inhibitor and don't take the ACE inhibitor, they do very badly. So the best thing you can do is persist with the ACE inhibitor as far as you can possibly do it. And I just make the point about SGLT2 inhibitors because they also are associated with this pseudo-worsening renal function. Here, the EMPEROR-reduced study of empagliflozin looking at renal function during the initiation of empagliflozin or matching placebo. You see here that as early as 4 weeks after randomization, there's an acute fall in GFR. Thereafter, the slope of further deterioration in GFR is significantly flattened in the patients randomized to the SGLT2 inhibitor with a slope of minus 0.9 mils per minute per 1.73 meters squared on empagliflozin compared to 4.2 mils per minute per 1.73 meters squared on placebo. So that shows an ongoing protection of renal function. This early reduction is a hemodynamic effect, but thereafter you get preservation of renal function. At the end of this study, the GFR is better on empagliflozin, and in patients in this study, when the SGLT2 inhibitor was stopped at the end of the trial, the GFR bounced right up again, showing that there was an acute hemodynamic effect, apparently suppressing GFR. There's not a real reduction of GFR. So these truly are kidney protective agents, and we should not be scared of that early reduction in serum creatinine. In summary, renal impairment is a very important part of the heart failure syndrome. We need to monitor it throughout our patients, both acutely when in hospital, chronically, and when we're starting guideline-directed medical therapy. Worsening renal function, as estimated by elevated serum creatinine, is not necessarily a bad sign and certainly should not be a reason not to persist with our best treatment advice, and that is adequate decongestion and full dose neurohormonal modulation and full dose guideline-directed medical therapy where they can be tolerated. Diuretic-induced worsening renal function is not always deleterious. It's better to go for adequate congestion. Adequate decongestion, persistent congestion is a poor sign. Renal function and RAS inhibition, try to get the patient back on some dose if you can, and SGLT2 inhibitors benefit both the heart and the kidney, and the transient initial reduction in creatinine is not something that should lead you to stop the treatment. Thank you very much.
Thank you.
Thank you.
Dr. Coates. Is Dr. Coates here?
Sir, Dr. Coates has still not been able to join us from the case. So I just discussed with Dr. Abraham Oman, who said you and Professor Venugopal could take a discussion for about 5 minutes.
Do we have 5 minutes because of
yes,
next
sir.
topic to 22?
No, we have 5 minutes.
Time. Okay, go ahead.
So
I think, go ahead, Dr. Chopra.
yeah, so this is always a problem. Patients, the sicker the patient, the worse is the problem of renal dysfunction. And I like Dr. Coates' term, self-inflicted lack of data. The sickest patients that we have with significantly reduced creatinine clearance, we don't have any reliable data in that. But this is always a problem, and I think it is important. Dr. Coates' presentation very adequately highlighted that it's more important initially to achieve adequate decongestion, because it is the venous hypertension or the venous congestion which is worse for renal functions. And so long as you take care of it, in course of time, it would improve. One question which always comes up, about which there is a controversy, is infusion of diuretics or intermittent bolus doses. The data on that is still mixed, but I think when push comes to a shove, many of us would still use infusion of intravenous diuretics. The third point which comes up many times is that whether you want to use furosemide or you want to use something like torsemide, because theoretically at least the electrolyte disturbances are less with torsemide than with furosemide. Given intravenously, the efficacy of both of them is similar, but on a long-term maintenance basis, torsemide has a better bioabsorption from the gut as compared to furosemide. So these are some of the additional points. Dr. Venugopal?
Yeah, I think I have to reiterate most of the points that you also said. That we are always scared when there is a slight worsening of the renal function. Our first priority is to reduce the diuretic dosage or to reduce the ACE inhibitor dosage. In chronic heart failure, Dr. Coates has very clearly said that it is always better, the patients who continue on ACE inhibitors do better than the patients who have actually stopped ACE inhibitors. So that's a very valid point that we need to keep up, especially when there is a mild rise in creatinine. We tend to stop. I think we should continue this. Again, another thing that he mentioned is one of that practice that we don't really do in India is probably measuring the urine sodium concentrations after 2 hours of diuretic dosage, probably for practical reasons. And looking at the urine output is very easy for us to measure. But urine sodium, I think most of us do not really do it. I think it's something which we need to look at in our own practice. And again, attaining decongestion is far more important than the worsening of the renal function. That is a point that he highlighted. People who have slight renal dysfunction but still attain decongestive status do far better than those who do not attain decongestion. So these are some of the points that he highlighted. I think, and regarding diuretics, as Professor Chopra said, there is always a controversy as to which diuretic we use in our own practice. I basically prefer furosemide for acute patients, but for chronic patients, I tend to go for the longer acting torsemide because of its lesser metabolic effects when compared to furosemide. Is there any other comments? Any questions or comments? Any chats?
And another thing is then, if diuretic resistance is there and people are still waterlogged, using ultrafiltration is again a reasonable alternative.
Yes.
Because many times it tilts the balance and brings the person into a more hemodynamic stability. And once they lose a little bit of fluid, then they start responding to diuretics even better.
Yes, I agree with you. The ultrafiltration is something which a little underused modality in acute heart failure, I believe.
So there are two comments rather.
Yeah.
Your comments on continuous furosemide drip against bolus doses. Do you prime them with potassium retaining drugs? And in his experience, he has found that good results with furosemide drip along with albumin is very good.
If you look at the continuous versus this thing, I think there is very little to choose between. I think most people prefer to use intermittent diuretic dosage. That is, the algorithm also says that what is shown by Dr. Coates also shows intermittent diuretic dosage. Even though many people use continuous intravenous infusion of furosemide, I personally prefer intermittent doses of diuretics. Dr. Chopra, your comments on this? Is there any difference in your approach?
We step up diuretics, double the dose every 4 to 6 hours, depending upon the response. But we do use infusion of furosemide if things really look bad.
What about the other part, the albumin part? I don't usually use that.
I fully understand the certain trials mentioned that it really makes no difference. But this is something that we practice at times. I think we can go on to the case because it is about time.
Yeah.
And there's interesting discussion going on. So let's go on to the next presentation.
Can I start?
Yes, Dr. Rakesh, you're on.
Go ahead.
Yeah, this is a case of a 55-year-old lady, diabetic and hypertensive, dyslipidemic, with a family history of heart disease, premature CAD, and who presents with acute onset breathlessness. Her echocardiogram shows EF of 35%, RVSP is 55, mild to moderate pH. She has history of an MRM done, modified radical mastectomy 10 years ago for CA breast, and has received anthracycline-based chemotherapy. The cumulative dose was 550 mg per meter square. It is followed by targeted therapy, that's trastuzumab, and then she has history of recent stress. This is also important. So how come this patient who had an injury which happened 10 years ago, now present with breathing difficulty? It's in fact a kind of a quadruple hit. The patient has had multiple coronary risk factors, and she had an acute onset. If you look at the actual data of the patients who present with heart failure following chemotherapy, You can see an abrupt onset during infusion itself. Some patients can present with frank heart failure and arrhythmias, but this is only less than 1%. Though in every case, the injury caused by the adriamycin or any sort of chemotherapy drug occurs during the infusion or immediately after that during the half-life of the drug itself. And in fact, adriamycin causes apoptosis and necrosis of the cardiomyocytes, and cardiomyocyte damage is typically permanent. But these patients present with breathing difficulty, LVF, much later, years later usually, though it can manifest as early as 1 year or 2 years from the date of exposure. This is something that is typical. Then why is it so-called delayed presentation? The reason is the heart has significant cardiac reserve. Even if the injury occurs during the immediate phase of the drug use, there is a lot of compensatory mechanisms which prevents the heart failure symptoms. And when the patients typically, as the age progresses, when the compensatory mechanisms fail and there is negative remodeling, they present with breathing difficulty and airway dysfunction. There may be an added component of new injuries like use of drugs like trastuzumab, or a patient who has already had adriamycin or paclitaxel or another hip cancer which you have happened to use another chemotherapeutic drugs. The new injuries will probably contribute to further myocardial damage and heart failure. And typically, most of these patients who have cancer get a bad deal on treatment of other risk factors like hypertension, diabetes mellitus. Take my word for it, because people think that cancer is something like inevitably fatal. So, if they have some hypertension or diabetes, why should you treat it? So, this is a common problem which we face in all patients with cancer. So, if you have uncontrolled risk factors like hypertension, diabetes mellitus, dyslipidemias, these patients can have not just myocardial infarction, even otherwise it will promote heart failure. And stress-induced cardiomyopathy occurs in many cancer patients. Some of if you look at the actual data, only adriamycin, cyclophosphamide, and paclitaxel could possibly cause a LV dysfunction per se. Then other drugs, patients on other drugs too can have heart failure. It may actually be stress-induced cardiomyopathy. Stress-induced cardiomyopathy actually occurs in many patients with cancer, and it is not as benign as it will be used thought earlier. The mortality of the patients who get stress-induced cardiomyopathy in cancer at the end of 1 year is same like a person who had continuous valvular dysfunction. Now somebody is going to talk about it. What are the incidence of cardiotoxicity with adriamycin use? It is up to cumulative dose of 400 mg square. It is relatively less. It's the risk of injury, not heart failure, to 32%. And when it is more than 550, the risk is 65%. And if you're using 500, it is 54%. So quite a significant number. But why this drug is still used is because the drug is very effective in cancer. And typically, both systolic and diastolic dysfunction can occur. And dilatation and systolic dysfunction of the RV can occur during an immediate phase of anesthetic infusion, but it is usually not maintained. And thinning of the left ventricular wall is very common. And LV may or may not be dilated. And LV is frequently small for the body surface area in a person who was exposed to adriamycin in younger life. Because of fibrosis, as the heart size does not come up. So you'll find somebody with acutely breathless, severely breathless, with normal sized heart, but it is small for the body surface area. The adult survivors of cancer are at 5 to 6 times at risk of developing heart failure. It is something important. This incidence is much more than the common population, general population. Little about trastuzumab is a targeted therapy. Some 4% patients with heart failure, especially will develop heart failure if they are already exposed to anthracycline. But the thing is, it occurs primarily due to uncoupling of the energy kinetics. And the electron transport chain gets uncoupled. So that leads to a kind of reversible myocardial injury. So it's very important to see this patient, however, they have cardiac shock, whatever you should do, everything in your capacity to treat such patients, because essentially this injury is completely reversible. Only 1% of the patients with trastuzumab injury will not have a complete reversal of the LV dysfunction, but majority will have a good response. And most patients with trastuzumab, even if they develop LV dysfunction, we may not have to stop this therapy at all, because we know it is reversible and it is essentially treatable. See, anthracycline-induced myocyte damage is the type 1 injury. It is permanent. And this is something which has gone into the minds of most of us. So we think it is permanent injury, so we can't treat it well, or we can't treat it good. This is a very wrong concept. It is true that the myocardial injury is caused by the adrenomycin is permanent, but the heart failure is eminently treatable. All neurohormonal manipulations will work in chemotherapy-related dysfunction. You don't have to hesitate at all. All of them will work well. Maybe there are some advantages of sacubitril valsartan in this group of patients. The last trials are ongoing. That will give us an answer. The initial trials typically excluded, all the heart failure trials have typically excluded patients with cancer. I don't know why that should ever be done. That's been done. It's been unjust. SGLT2 inhibitors, all I can tell you, all my patients on heart failure with a brief gestation fraction are on SGLT2 inhibitors, because I believe it causes the kind of diuresis and reduces central venous pressure, and it reduces cardiac fibrosis, and outcome in this patient with the cardiorenal syndrome also is very good. So we do use it, and we have now the trials on SGLT2 inhibitor with the reduced ejection fraction that benefit the patients. And digoxin, we just had a recent, I was listening to a discussion about a little earlier. The digoxin is not a primary stay for us in patients with cancer and elbow dysfunction, because digoxin obviously is not shown to benefit in terms of the mortality statistics. But we do treat people with digoxin in those patients who have hemodynamics can't allow us to use a significant amount of vasodilators, which sets us tend to have hypertension. In those patients, we put them on digoxin and subsequently withdraw it after 4 weeks or 6 weeks. Then mainstay will still be on vasodilators, MRAs and beta blockers and everbradin. And we don't use diuresis as a mainstay. Diuretics are used only when the patient presents acutely to relieve the symptoms. And since diuresis are not known to shown to have mortality benefit, we don't use diuresis as a mainstay, and then we continue to use this people with a volume loaded status will much better tolerate vasodilators, beta blockers, and all sorts of neurohormonal manipulation will probably work better in this patient, and they will tolerate it better. We give a choice to the patient, and if you say if you are feeling breathless, then you can use diuresis. And if these patients who have on all optimal therapy and still is volume loaded, we do use diuresis. And it is very, very important to control all the risk factors patient has, including diabetes, hypertension, dyslipidemias. And if you don't do that, this is something which can lead to further deterioration of the cardiac pumping, and which can lead to further heart failure. And dexamethasone is a drug which is known to prevent injuries in patients during other cycling infusion, but it is not used in adult population for whatever reason. Used in children who get very high dose of anthracyclines. In them, it has shown some benefit. But something I want to tell is that if you put these patients on vasodilators before they develop elbow dysfunction, there are some anecdotal trials and experience about it, but it is not shown really to be beneficial, because the injury is said to happen, and heart failure should occur, neurohormonal activation should go haywire, then only this drug should act. Hypertension, cancer therapy, cancer patients are particularly at high risk of developing hypertension and worsening hypertension. And hypertension, cancer, and CKD and CVD as common risk factors, including diabetes, smoking, and obesity. Certain cancers itself cause hypertension, and it can also occur as a part of paraneoplastic syndrome. And cancer survivors are more at developing CKD, and patients with CKD are more prone to developing cancer. So essentially is that treat hypertension well, and treating hypertension and diabetes is the most frequent event that happens in patients who develop heart failure. And if you follow guidelines, you essentially follow guidelines, the SCC guideline, you may not give chemotherapy to many people. Post-surgical cardiography is not that high in India, so we should have our own guidelines. I strongly feel Heart Failure Society of India should start a cardio-oncology division. It's a need of the hour. It is primarily cardiology. GLS has not made a big difference in the outcome of treating this patient, and we need to individualize the follow-up. Onset of elbow dysfunction is not the end of the road, and treating doctors needs awareness that heart failure is not the cure of eternal suffering from cancer. Thank you.
Thank you, Dr. Rakesh. I think we'll go to the next talk, that is stress cardiomyopathy by Dr. Ambuj Roy. Dr. Ambuj. Dr. Ambuj?
Yeah.
Can you share?
I've sent my recording. I didn't know I have to say speak live.
Sir, we will.
Okay.
Sir, we will play the recording, sir.
Yeah.
1 second.
Coming.
Can you have slides, please?
Yeah.
Sir, we will play the recording, sir. 1 second.
Coming up.
Sir, we will play the recording, sir. 1 second. 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 1 second.
Good evening, everyone. At the outset, let me thank the organizers for inviting me to give a talk at the HFA conference. So I've been asked to speak about stress cardiomyopathy in this case-based session, a relatively enigmatic condition, and I'd like to bring out a little bit on the newer facets of this disease that we have learned as we gain more and more experience with this disease. 55-year-old lady has a history of mastectomy, comes with class 2 breathlessness, is a diabetic, hypertensive, and she has had recent stress, and her ejection fraction is 35%, RV systolic pressure is high, and a TAPSE is 12. So the question asked is, could this be stress cardiomyopathy? Well, we obviously would require some more information, what the ECG is, how does the echo look, and how is the coronary angiography. So to understand on how to make a diagnosis of stress cardiomyopathy, I would like to speak on the 10 facets of this over the next 10 minutes. So to beginning with nomenclature, I think this is quite well known. It's known by several other names like Takotsubo syndrome, the Takotsubo being a Japanese contraption which is usually a fishing pot used to trap octopus. As you can see in this picture, or it's also called the broken heart syndrome or the apical ballooning syndrome, and was first reported from Japan only as recent as 1990. And since then, of course, as I mentioned, we have come to know more and more of disease. And as the awareness of this disease increases, you will, in some of the series of acute coronary syndrome, as many as 1 to 2% of these patients have stress cardiomyopathy. So obviously, you need to have a high degree of suspicion to make this diagnosis. And the incidence is approximately 15 to 30 cases per 100,000 reported from United States. But very importantly for making a diagnosis, as in our case, this is more common in postmenopausal women. More than 90% of cases are women, and the age is above 60 years in most of the cases. The mean age is above 60 years of age. Importantly, what is the pathophysiology? So as we know, as the name suggests, it is precipitated by stress. Very importantly, this need not be always negative stress, and as you can see, even positive stress can lead to this condition. And along with physical stress, emotional stress, there is a activation of the pituitary hypothalamus axis, which leads to, through mediators, causes direct cardioinhibitory effects or causes acute microvascular dysfunction, which leads to stress cardiomyopathy. Of course, there are certain risk factors besides gender and postmenopausal stage. It's been like patients with psychiatric disorders, diabetics, substance abuse disorders, which kind of make you more prone to stress cardiomyopathy. So what is the typical clinical presentation? Most of the time, as I said, as in our case, if it is a primary form, it usually presents an acute coronary syndrome, so postmenopausal women with chest pain in more than 75% of the cases, or they can present with shortness of breath, which may again happen in up to 50% of the cases. There may be dizziness, which is the other form of presentation, or there can be occasional patient who may present with syncope in 5 to 10% of the cases. But there is another facet of this disease, which is not here in our case, but it's a secondary form which is always more difficult to diagnose, and this stress cardiomyopathy happens in the setting of another critical illness, where a patient has admitted to a hospital with another disease and is critically ill, and then may have a new onset of arrhythmias, or may develop hypotension, acute pulmonary edema, or suddenly develop normal ECGs, troponin elevation. And here it is important to keep a high index of suspicion to diagnose stress cardiomyopathy. One of the very important aspects of diagnosing stress cardiomyopathy is to look at the ECG changes. There are some ECG changes in almost all cases. However, ST segment elevation, as we classically know stress cardiomyopathy to be associated with, happens in only 40% of the cases. In other cases, there may be T-wave inversion, there can happen deep widespread T-wave inversion, and more importantly, significant QT prolongation. When you're seeing in such patients, you must suspect stress cardiomyopathy. Progressive QT prolongation to more than 500 milliseconds is commonly reported. Importantly, ST segment depression is quite uncommon in these patients, and so whenever you're seeing ST segment depression, think of another diagnosis. It's unlikely to be stress cardiomyopathy. And of some of the newer aspects of ECG changes which are relatively specific for stress cardiomyopathy have been brought out. ST segment depression in AVR, when combined with ST segment elevation in anteroseptal inferior leads, can be very specific for stress cardiomyopathy. And I'd like to just dwell a minute on this. In this excellent paper in the Journal of American Heart Association, they've described ECG for patients with ST segment elevation who present with stress cardiomyopathy versus non-stress cardiomyopathy, and similarly for non-ST segment elevation with stress cardiomyopathy versus usual non-ST segment elevation. So whenever you see ST elevation, they write in minus AVR, which basically means ST depression in AVR, with no ST elevation in V1. And when you see ST elevation in ST depression in AVR and no abnormal Q waves, and ST depression in AVR associated with, as I said, ST elevation in inferior, anterior, or anteroseptal leads, then you can diagnose ST elevation with Takayasu's cardiomyopathy with more than 95% specificity. So although this sign of ST depression in AVR with ST elevation in inferior or anterior leads is not very sensitive, but it's very specific for diagnosing stress cardiomyopathy. Similarly, when you get ST elevation in AVR, you're more likely looking at usual STEMIs. Coming to the non-STEMI presentations of Takayasu, so if you see T inversions in lead 1 AVR B5 B6 and ST depression in AVR, or for that matter ST depression in AVR associated with T inversion in any lead, then we are looking at very likely looking at Takayasu cardiomyopathy. And this is from one of the cases which we had recently, which is a secondary form of Takayasu, which we recently saw in a patient with pancreatitis. There was clear ST depression in AVR lead. So this is a sign you should look for when you're looking at, when you find this, you should highly suspect stress cardiomyopathy. So in biomarkers, unlike ACS, it's important to know the troponin levels are not as high, but BNP levels are much higher as compared to ACS. So that is something which helps you distinguish ACS, usual ACS from stress cardiomyopathy. Imaging is a very important facet, and apical ballooning with LVOT obstruction due to basal hypercontractility and mitral regurgitation due to systolic anterior motion of the AML is common and classical finding. But however, as you can see here from the diagram, there are other variants where there could be mid-ventricular ballooning, or there could be inverted, where actually the basal ballooning happens of the myocardium as compared to the apex, or rarely there can be biventricular, which is usually present with severe hemodynamic compromise. Coronary angiography is usually normal, or unless sometimes you do find bystander CAD. So if the other signs are fitting with stress cardiomyopathy, we should not get diverted to classical CAD diagnosis. There may, because these are elderly, you may get bystander coronary artery disease. Most often, however, classically it's coronary angiography normal. Ventriculography may need to be done. sometimes, especially when you want to detect mid-ventricular forms, which are difficult to pick up on echo. And CMR is the other imaging modality which has come up and which shows edema in the areas of regional wall motion abnormality, which usually does not fit with the distribution of epicardial arteries. So if you're seeing that, suspect stress cardiomyopathy. This is the diagnostic criteria given by the Intertac diagnostic criteria based on the large registry, and these are the points based on what the ECG finding, the gender of the patient, the trigger, and whether there is associated neurological psychiatric disorder or not. And if the score is more than 50, then you should suspect Takayasu with a specificity of more than 95%, and however if less than 31, it's unlikely to be one. Treatment is predominantly symptom driven, so you treat pulmonary congestion with venodilators, diuretics, arterial vasodilators. If there is cardiogenic shock with LVOT obstruction, then beta blockers may help, and you avoid inotropes. But if it's without LVOT obstruction, then inotropes are of quite a lot of use. I would just mention that anticoagulations are quite useful because they have a lot of thromboembolism in this condition because of a large akinetic area. So we should consider that. As compared to the cause, we know it's usually benign, but acutely the in-hospital mortalities can be up to 5%, especially in secondary forms because of other critical illnesses. Thrombi formation can happen in 10% of the cases. Recovery of the LV contraction usually happens gradually over 1 to 2 weeks, but can take up to 6 weeks. However, we must keep this in mind, which is not commonly known, is that the recurrences are common, and up to 20% of people may have a recurrence of stress cardiomyopathy at 10 years. So in summary, think of stress cardiomyopathy when you have a patient presenting with chest pain, breathlessness, is an elderly woman. There is an emotional trigger. ECG is showing AVR ST depression and ST elevation in inferior lateral leads or T inversion in one of the leads. Regional wall motion is showing apical ballooning, and there is a normal angiogram. And this diagnosis is confirmed by near complete recovery at 3 to 6 months. Thank you so much.
Good evening, everyone. Next few minutes, I'll be talking about pulmonary hypertension and right ventricular failure, dysfunction in heart failure, no longer the dark side of the heart. So in these slides, we'll see what is the light side and what is dark side. As you know, pulmonary hypertension in group 2 pulmonary hypertension is secondary to heart failure, which may be systolic heart failure, diastolic heart failure, or valvular heart disease. The pulmonary hypertension is often a passive transmission of the left ventricular end diastolic pressures, which are transmitted to left atrium to the pulmonary arterial tree. Additional factors will be neurohumoral activation with increased endothelin and decreased nitric oxide in the pulmonary vasculature. A permissive genotype will increase the chances of pulmonary hypertension. In patients with heart failure with preserved ejection fraction, inflammatory, metabolic, and oxidative stress contribute to the generation and progression of the pulmonary hypertension. As the pulmonary hypertension develops, right ventricle dilates, it hypertrophies, tricuspid regurgitation comes, and RV dysfunction sets in. This leads to clinical right heart failure and adverse outcomes. As you know, the group 2 pulmonary hypertension can be divided into post-capillary pulmonary hypertension or combined pre- and post-capillary pulmonary hypertension. Post-capillary pulmonary hypertension is essentially pulmonary venous hypertension, in which the pulmonary artery wedge pressure increases to more than 15 millimeters of mercury, PA mean to more than 20 millimeters of mercury, and pulmonary vascular resistance remains less than 3 Wood units. Whereas in combined pre- and post-capillary hypertension, it is a combination of the arterial hypertension as well as the venous hypertension, in which also the artery wedge pressure and PA mean pressure are elevated, but because of the arterial pulmonary hypertension, the pulmonary vascular resistance is more than 3 Wood units. This pulmonary arterial component may be because of vasoconstriction alone, which is reversible with vasodilators, and with vasodilator challenge, PVR decreases to less than 3 Wood units. This is called reversible or reactive pulmonary hypertension. But with long-standing pulmonary hypertension, there will be structural remodeling, structural changes. It becomes irreversible and fixed, and vasodilator challenge does not decrease the pulmonary vascular resistance. This is called irreversible fixed pulmonary hypertension. Now, how does the right ventricle behave in left heart disease? Right ventricular function deteriorates with progressive worsening of the pulmonary hypertension. It's a determinant of prognosis in the heart failure. The mechanism of right heart failure in this setting include afterload mismatch due to increasing pulmonary hypertension, right ventricular ischemia and CAD and lower push states. Intrinsic myocardial dysfunction may be seen in dilated cardiomyopathies. Ventricular interdependence because of the shared septum and also pericardial cavity lead to the right ventricular dysfunction. Presence of pulmonary hypertension and RV dysfunction indicates more advanced left ventricular dysfunction, which is often associated with more diastolic dysfunction. These patients more often have atrial fibrillation, mitral regurgitation, and congestive state requiring diuretics. Now, presence of RV dysfunction is associated with increased hospitalization and mortality, and various parameters of RV function are known, which indicates poor prognosis, and they should be measured routinely in clinical practice. And response to right ventricular dysfunction to treatment is variable and evolving. This slide shows the varying incidence of pulmonary hypertension and right ventricular dysfunction in patients with left heart failure. The prevalence of pulmonary hypertension varies anywhere from 25% to 80% based on the type of the method used to estimate the pressure, whether it is echocardiography or invasive, how they divide pulmonary hypertension, and the kind of population studied. And among the various parameters, hemodynamic parameters that one should know about right ventricular function, I will be talking about 4 parameters. Cardiac filling pressures, this is the ratio of right atrial to pulmonary capillary vent pressure. PA pulsatility index, PAPI, this is PA systolic pressure minus diastolic pressure, that is pulmonary artery pulse pressure upon right atrial pressure. The RV stroke work, the work done by the right ventricle, that is the pressure generated, that is mean pulmonary artery pressure minus right atrium into stroke volume into 0.0136. RV stroke work index is mean pulmonary artery minus RA divided by stroke work index, stroke volume index. All these parameters are important to understand the intrinsic right ventricular function. In a study published in European Heart Journal 2020, the authors have shown that pulmonary hypertension and right ventricular dysfunction together are associated with are markers of prognosis. In patients who have got right ventricular dysfunction, they consistently do worse than patients who have got right ventricular normal function. So here we see no pulmonary hypertension, no RV dysfunction. This subset of patients with LV dysfunction do very well compared to those here red line who have got both pulmonary hypertension and right ventricular dysfunction. They have come out with another parameter, which is the ratio of TAPSE to systolic pulmonary artery pressure. This is a marker of right ventricle to pulmonary artery coupling, and if the value is more than 0.36, the prognosis is better. Less than 0.36, the prognosis is poorer. There is another marker, PAPI, as I mentioned. This is the pulmonary artery pulse pressure upon right atrial pressure, and high PAPI, better prognosis, low PAPI, worse prognosis, both for death and hospitalization. As mentioned, these 4 parameters are important, especially in patients selected for insertion of LVAD. If these parameters are not favorable, patient is likely to go into right heart failure soon after the LVAD insertion. So it is very important that the operator looks at these parameters and satisfied that the right ventricle they can take up the work after the LVAD insertion. And this algorithm for the decision-making algorithm for the pulmonary hypertension is heart transplant is well known to everybody. Any patient who is concerned for heart transplantation has to undergo right heart catheterization. If the PA pressure is less than 60, TPG is less than 15, and PVR is less than 3, he straight away goes for heart transplant. If the parameters are high, he goes for the hemodynamic testing to assess the reversibility of the pulmonary hypertension. If the reversibility is there, he goes for heart transplantation. If it is not reversible, he goes for LVAD. Or on LVAD, over a period of time, the pulmonary artery pressures and PVR decrease and becomes a candidate for heart transplantation. This chart here shows the effect of pulmonary vasodilators in treating the pulmonary hypertension due to left heart failure. The epoprostenol, the prostaglandins, endothelin receptor antagonists, and PDE5 inhibitors are used in the pulmonary artery hypertension. And thinking that the pulmonary vasodilators benefit this patient, these were studied. But the results are mostly negative or neutral, except PDE5 inhibitors, which has improved exercise performance and some hemodynamic parameters, but not the clinical outcomes. Gali has pointed out that in all these trials, The mortality in the active drug arm is more than the placebo arm, which means the drugs can maybe actually be harmful to these patients, and one should be very careful in using the pulmonary vasodilators in the treatment of pulmonary hypertension due to left heart failure. Whereas where the drugs don't work, LVAD seems to work. In all the studies which have studied the effect of LVAD on the pulmonary hypertension, the PVR and mean pulmonary artery pressure and TPG have improved after the LVAD insertion, making the patient a candidate for heart transplant. Soon after the LVAD implantation, as the LV is unloaded, cardiac output increases. That actually increases the preload to the right ventricle. Because of the shape changes, septum is pushed to the left side, and the geometry changes and contractility decreases. And though the passive component of the pulmonary hypertension, that the pulmonary venous hypertension decreases, pulmonary arterial tension persists, and it actually the afterload persists, and sometimes the patients may go into acute right ventricular failure after the LVAD insertion. And persistent pulmonary hypertension is not uncommon after LVAD, seen in almost 40%, and in about 10% of the patients, late right ventricular failure may occur. This is associated with poor prognosis, and there is some suggestion that the PDE5 inhibitors are useful. They are recommended for the use in these patients, with a caveat that the benefit is not scientifically and proven in sufficient number of patients. Both bosentan and sildenafil are used in these patients. In a small study, sildenafil used in the patients with LVAD has improved the cardiac output, decreased the mean pulmonary artery pressure and pulmonary vascular resistance significantly. Not all patients can afford pulmonary, left ventricular assist device. We have given in one patient rigorous milrinone infusion continuously for 2 weeks with aggressive diuretics. In this patient, pulmonary artery pressure significantly decreased from 46 to 16 over time, and also PVR decreased, and patient underwent heart transplant successfully. This particular graph, people should be familiar. This shows the relationship between pulmonary vascular resistance and pulmonary arterial compliance. On the x-axis, we see the exponential description of the pulmonary vascular resistance, and pulmonary arterial compliance is the stroke volume increase per millimeter mercury rise in the pulmonary vasculature. In this graph, at a point of A, when the pulmonary vascular resistance is decreased, the cardiac output increases, and the pulmonary arterial compliance increases. This can be achieved by diuretics, anti-failure therapy, valve replacement as needed. But if the patient is lower down here at the point B, these medication alone are not sufficient. Patient may require therapy with LVAD or heart transplantation, as the case may be. In patients with pulmonary hypertension due to HFpEF, one can use pulmonary vasodilators very cautiously, taking so many factors into consideration. But if the patient moves to point C or point D in this x-axis with a higher pulmonary vascular resistance, he may not respond to treatment, and patient may continue to deteriorate. Cardiomyopathy has been used in the Western world for the past so many years. It is an implantable pulmonary artery pressure monitoring device. It guides the treatment with vasodilators and diuretics. They can be titrated. Decompensation and heart failure are prevented, and progressive worsening of pH and RV dysfunction can be prevented. In conclusion, we need more pathophysiological studies and longitudinal studies to understand the right therapeutic targets and therapeutic agents in treatment of this disease. Thank you.
Thank you. I think we have about 2 minutes for discussion, 3 minutes for discussion. Regarding this case, I think probably this patient had a previous cancer surgery, underwent chemotherapy, and the dose of anthracycline used was more than 550. So I think probably the most common diagnosis that somebody would make would be a drug-induced cardiomyopathy, even though the stress could have added to her clinical worsening, recent clinical worsening. And I would, for management of this patient, I would suggest a coronary angiogram in this patient without any obstructive lesions, and then manage her according to her cardiovascular status. This would be my approach. From you.
Ask Ambuj, you mentioned that some of these patients who get stress cardiomyopathy, they are more predisposed to have it later on, even up to 20% in some instances. Is there a genetic marker which can identify these people? I mean, if they have had it one, are they more likely to get it again?
What is known is that recurrences do happen, and they can go up to, as I said, 20% over the next 10 years. But I'm not sure about any genetic marker to identify the recurrence. I don't know, Stephen is here, he might add to it.
Stefan, any words of wisdom from you?
They come in my talk. I really just joined 1.5 minutes ago, so it's okay.
Okay. No, the question was people who get stress cardiomyopathy, many of them are more predisposed to have it in subsequent years.
Genetic background.
Marker which can identify these.
You tell me, Vijay. You're the expert.
Okay.
I don't think it's reported from whatever I could review the literature, and but yes, they are prone to recurrences. It's something that is not so well known, so I just wanted to bring that aspect out.
There's some data to show these patients' mortality at the end of 1 year, even if they recover from the cardiomyopathy completely, the same like the other person who had a dysfunction with the same duration.
So, as I said, there are two forms, the primary and secondary.
Primary and the secondary.
Secondary form, obviously, because they have other comorbidities, so the mortality would be higher. The primary form should do better than most LV dysfunctions because it's essentially reversible at the end of 12 weeks. I mean, that's one of the definitions for stress cardiomyopathy.
Rakesh, how reliable is DLSS in identifying early stages of myocardial dysfunction in cardiac involvement in oncology with these drugs?
Yes, sir. GLS definitely tells us the patient might develop LV dysfunction. But the thing is, practically it makes no difference in the management because the LV dysfunction is yet to occur. Because that's not going to make him the chance of how we manage with the vasodilator, that kind of thing, not yet proven. It's not that LV dysfunction will be treatable at that stage. Even sacubital valsartan is not very effective in people with a mild LV dysfunction. It's really people with significant LV dysfunction. But there is definitely an unmet need of treating this patient with cancer and cancer-related therapy, related LV dysfunction, cardiac involvement, hypertension. See, the hypertension behaves very differently in people with cardiac issues.
Okay.
And the nitrate may be more effective in that. I strongly think we should have CSI and Hospital Society of India should have oncocardiology division. It's in need of the other.
I think we have run out of time. Thank you very much for 3 excellent talks, and let's go on to the